Today we are going to learn about the spectrum of the commonly used antibiotics in clinical practice, specifically in the USA, and we are going to do it differently. So instead of studying the families of antibiotics, let me give you these fill-the-blank questions to get a taste of the information we are going to have in this episode. Let's go to the studio, or at least what I call the studio. It's getting cold really early this fall. All right, let's go. Antibiotic either works against gram-positive, gram-negative, or anaerobes, or a combination of them. This means we have three spectrums: anti-gram-positives, anti-gram-negatives, and anti-anaerobes. Based on this, antibiotics can be a single, double, or triple spectrum. Let's start with the single spectrum antibiotics. This includes pure anti-gram-positives, pure anti-gram-negatives, and pure anti-anaerobes antibiotics. Metronidazole or Flagyl is the only pure anti-anaerobes antibiotics we're going to talk about. It has 0 gram-positive or gram-negative coverage. The following antibiotics have pure anti-gram-positive coverage without any clinically significant anti-gram-negative or anti-anaerobic activity. Vancomycin, of course, linezolid, daptomycin, oritavancin, dicloxacillin, cloxacillin, oxacillin, nafcillin. The opposite to this group is a group of antibiotics with a pure anti-gram-negative activity but no clinically significant anti-gram-positive or anti-anaerobic activity. This group includes aztreonam, polymyxin B, and colistin. Now let's move to double spectrum antibiotics, and here we have two subcategories: the anti-gram-positive and anti-anaerobes category without any gram-negative coverage. Clindamycin is the only one in this category we're going to talk about today. Clindamycin covers gram-positive and anaerobes but has 0 gram-negative coverage. The second category, which is the anti-gram-positive and anti-gram-negative group, but without any clinically significant anaerobic coverage, and this includes the following. Are we ready to count? All cephalosporins except cefoxitin and cefotetan, which are active against anaerobes as well. Amoxicillin and ampicillin from the broad-spectrum penicillin, all quinolones except moxifloxacin, which is active against anaerobes as well, macrolides or lides, azithromycin, erythromycin, and clarithromycin, the tetracycline family, including, of course, doxycycline, and of course the aminoglycoside gentamicin, tobramycin, and amikacin. Remember that aminoglycosides are mainly used synergistically with other antibiotics. Now I'm going to put penicillin G and V here, but remember their anti-gram-negative activity is really minimal. Let's move to the big gun antibiotics, the triple spectrum coverage antibiotics. They are active against gram-positive, gram-negative, and anaerobes. Let's start, of course, with the carbapenems family. Second, the extended spectrum penicillin family, which includes zosyn, piperacillin/tazobactam, and ampicillin/sulbactam, amoxicillin/clavulanic acid augmentin, cefoxitin and cefotetan from the cephalosporin family, and moxifloxacin from the quinolones family, and tigecycline. Tigecycline is also the only one here in this group that's active against MRSA. Now, let's flip the coin now and talk about certain clinically relevant bacteria and to which antibiotics these bacteria are susceptible to. Let's of course start with the most popular one, MRSA. The following antibiotics are to a variable degree active against MRSA. IV vancomycin, remember oral vancomycin is solely used for the treatment of C. diff. Linezolid oral and IV, daptomycin IV only, ceftaroline IV only, tigecycline IV only, oritavancin IV only, clindamycin, Bactrim, that which is trimethoprim, sulfamethoxazole, and doxycycline. The last three comes in oral and IV form. Let's move to MSSA, methicillin-sensitive Staph aureus. Of course, the most commonly used IV agents in clinical practice are cefazolin or Anzef and antistaphylococcal penicillin, nafcillin, oxacillin. For oral use, cefalexin, which is Keflex, amoxicillin and clavulanic acid, which is Augmentin, cloxacillin, and dicloxacillin. MRSA antibiotics are theoretically active here against MSSA, but of course, in clinical practice, we reserve them for penicillin allergy patients. We use IV vancomycin if we need. Linezolid, clindamycin, and Bactrums are really the one to consider in such a case. Remember, these antibiotics are not as effective as first-line regimen for MSSA. For example, IV vancomycin is less active than cefazolin or antistaphylococcal agents. Please avoid using quinolones or ceftriaxone to treat MSSA, as resistance can develop quickly. Let's move to Enterococci, more specifically Enterococcus faecalis and Enterococcus faecium. Ampicillin or ampicillin/sulbactam unison, IV vancomycin, linezolid, and daptomycin are active against Enterococci. Aminoglycosides or ceftriaxone can be used synergistically with ampicillin in enterococcal bacteremia, but never alone. Which antibiotic to be used first should be guided by the type of infection and the sensitivity results. Let's move to anti-pseudomonal agents, the antibiotic that works for Pseudomonas aeruginosa. The following antibiotics may be active against Pseudomonas. That's why we always guided by the final culture results. Piperacillin/tazobactam or Zosyn from the extended spectrum penicillin family. The carbapenems family except for ertapenems, which is not active against Pseudomonas. Cefepime and ceftazidime from the Cephalosporins family. Ciprofloxacin and levofloxacin from quinolone families. They are the only available oral agents to treat Pseudomonas infection. Aztreonam and aminoglycosides. Remember, aminoglycosides are usually used synergistically with other antibiotics. Ceftazidime/avibactam, polymyxin B, and colistin are reserved for pan-resistant pseudomonal infections. Now, how about ESBL-producing bacteria? ESBL, extended spectrum beta-lactamase producing bacteria. These are mainly or are actually gram-negative bacteria, specifically E. coli and Klebsiella pneumonia. Carbapenems family is the antibiotic of choice here. If carbapenems cannot be used for any reason, high doses of cefepime can be used as a second-line agent. Do not pick piperacillin/tazobactam or other cephalosporins, even if the culture is saying it's sensitive to. They are not reliable. Next, Stenotrophomonas maltophilia, Bactrim or trimethoprim/sulfamethoxazole is the drug of choice. Quinolones are second lines for treatment. Remember that Bactrim is also the drug of choice for PJP infections. How about C. diff? Of course, fidaxomicin and oral vancomycins. Oral and IV metronidazole also has activity and can be used in some cases, especially in toxic megacolon. The IV flagyl can be added to vancomycin or fidaxomicin. Let me finish with legionella, mycoplasma pneumonia, and chlamydia pneumonia. These bacteria don't gram-stain well, so you cannot say gram-positive or gram-negative. Mainly mycoplasma pneumonia and chlamydia pneumonia. Respiratory quinolones or azithromycins are the drug of choice here. Remember, ciprofloxacin is not a respiratory quinolone and should not be used in community-acquired pneumonia treatment. At the end of this video, I hope it was useful to you and worth your time. Thanks for watching.